is the outcome, and that is saving the lives of our women. It is quite hurting when we hear 5,800 and above of our women are dying because of a disease that is curable and preventable if detected early. And so for this afternoon, because I have my presenters with me, I have three panelists who are very, very passionate in this area. And our first panelist is Madam Lilian Genga, who is working with the National Cancer Control Program. She's a lady who is passionate because she's dealing and spearheading the pillar that deals with prevention, early detection, and screening. And she has gone far even to help not only Kenya, even to help other nations in this world. And then my other panelist will be Madam Emma Kariuki. Emma is a technical advisor when it comes to women health because she's very experienced, especially for the last 2 decades. Emma is also a trainer and she's also a mentor, and she has a big heart on how she can save the lives of our women not to die because of cervical cancer. I also have another panelist who is a warrior, and she's called Emily Wekesa. She's going to speak more about herself on emphasizing how screening saves life. For me, I'm Lydia Kirika. I'm a lecturer. I'm also a health researcher, and I am also an epidemiologist. So when I hear of a disease, I so much like to know more of the disease, how it occurs, and also how it can be prevented, because intervention is key as an epidemiologist. So as for this, I want to say that because I want to save time so that you can have time to ask questions, I just want to request that for any question, kindly write on the chat. All those questions, we are going to address them if at all there'll be time. And for this, I want to usher my first panelist, who is Lilian Genga, so that she can take us through on the screening issues. She can update us on the screening according to the current screening guideline, which is for our second edition as a program for the year 2024. Lilian, take over.
Apologies. If I may just come in for a moment while I take you through the housekeeping rules that we do have. Please note that this session will be recorded. So keep your microphones on mute as we go through the presentations. Also, to be noted, kindly post all of your questions on our Q&A box so that it can be easier for our panelists to retrieve while we are answering them. And you can send comments or appreciations through our chat box. And also note that the CPD attendance will be tracked for these sessions so that we can be able to award CPD points according to your different cadres. Thank you once again for joining us. And now over to the NCCP team for today's session. Thank you.
Okay, thank you, Nelson, for the housekeeping rules. Lydian, it is your time.
Good afternoon, everyone, and welcome to the session. I'll take us through on the update on the national screening and early diagnosis guideline. So basically, we are going to see the scope of the guideline, the overview, and what is new in the guideline, and the results and referral pathways. So when we look at the scope of this guideline, we have two approaches. That is the screening and the early diagnosis. So under screening, we have population level screening, where population level screening, we cover cervical cancer, breast cancer, and colorectal cancer. And when we go to targeted screening, we cover prostate cancer, oral cancer, and retinoblastoma. So that is what the approach in the screening guideline is. And then we have the early diagnosis. Under early diagnosis, the guideline communicates on childhood cancers, esophageal cancers, lung cancer, and other adult cancers. So when you just look at the cervical cancer screening guideline, the guideline talks of eligibility criteria that any woman who has ever had sexual intercourse is eligible, but we have the targeted population. The targeted population is women aged 25 to 49 years. This does not mean that women who are over 49 years are not screened, but the target population is 25 to 49 years. Then the guideline is also taking us through screening methods. So we have the primary screening method as HPV testing, which is as strongly recommended as the gold standard for women over 30 years. And then we have also other alternative methods as one is visual inspection with acetic acid and pap smear where acceptable and where HPV testing is not available or affordable. So the screening guideline also is talking about screening intervals using HPV DNA test, where HIV negative women, it's every 5 years, and HIV positive is every 3 years using this HPV test. But we will look at it, and when we look at each method keenly and see what is covered well and the intervals. So when we just pick and see what is new in this revised guideline, the guideline emphasizes on HPV testing, whereby HPV testing is prioritized as the primary screening method due to its high sensitivity and specificity. And also, it is also emphasizing on self-sampling options. And in this, there is introduction of self-sample collection to improve access and reduce barrier to screening, especially in the low resource settings. Another emphasis is on single visit approach, where it encourages a screen and treat strategies within the same visit where feasible to minimize loss to follow up. Also, it emphasizes on primary healthcare workers, who are supposed to be trained in cervical cancer screening and triage and treatment. So when we go to specific testing, let us start with HPV DNA test. HPV DNA test is the recommended primary screening test for cervical cancer because it detects high risk oncogenic HPV types. That is the approximately 70% of HPV 16 and 18 types. It has the highest sensitivity for CIN2 and CIN3 lesions. And also it enables extended screening intervals for HIV negative to 5 years and women living with HIV for 3 years. So samples can be collected at the facility and also in the community when we use the community health promoters to go door to door. Also, HPV positive women are, when we can be triaged using VIA, colposcopy, cytology, or HPV genotyping. We also see that under HPV DNA test, single visit approach management is encouraged to reduce loss of follow-up. So on visual inspection with acetic acid, the guideline tells us that this is the screening method that utilizes 3 to 5% acetic acid, which detects acetowhite lesions in the transformation zone and is suitable for women with visible squamocolumnar junction typically less than 50 years. That is why we indicate 25 to 49 years. So less accurate in postmenopausal women due to the receding of the squamous junction. So subjective interpretation is also captured here, where accuracy depends on the provider's skill. So also we see that they support immediate it supports immediate ablative treatment if the lesion is eligible. So whereby this woman does not go home without being treated because the lesion will be visualized on the spot. So, and also we have the third screening method, which is cytology. That is the pap smear. So we have the laboratory-based microscopic examination of cervical cancer cells. And also we have the type 2. There are two types. That is the first one, the one which is microscopic examination. It is the laboratory-based microscopic examination of cervical cells. And we have the conventional pap smear or liquid-based cytology pap smear. There are two types. So this supports triage of abnormal screening results, and it requires a strong referral and follow-up systems. And basically it cuts across from the age 25 and above. So it covers all the women. So when we go into algorithms, we'll start with the HPV, algorithm. Whereby when HPV test is done and the results are when HPV test is done and the HPV results are negative, we do rescreening after 5 years for HIV negative women, and for HIV positive women we do rescreening at the interval of 3 years. And when HPV HPV test is done and the results are positive, we avail colposcopy. If colposcopy is available, we perform colposcope, and if negative, we screen every 12 months, and if positive, we do a biopsy, and if there is no biopsy, when it's positive, we do a biopsy, and if it's CIN2, we do LEAP or refer for ablation if eligible. If CIN1 or less, we screen again within 12 months. But if where there is no biopsy and it's eligible for ablation, for ablation treatment, we do the treatment and do follow up using thermal ablation or cryotherapy, depending with the size of the lesion. So when the HPV positive and we do not have a colposcope, let me just run this again. It's a bit, the diagram is a bit blur, so it's making me strain a bit. Just bear with me shortly. I magnify it better. Just shortly, I'm magnifying it. Yes, it's better on my side. So, where colposcopy is not available, so we determine eligibility for ablative by using
Apologies. Lydia, I think we have lost Lillian. Can you still hear her from your end?
Oh, I'm not able to hear her.
To attendees, we apologize for the small technical hitch as we are sorting out Lillian to come back once again. Please note that today's session is focusing on diagnosis, or rather screening and treatment of precancerous lesions. Our last session last week was uploaded to our YouTube page. You can find it there. And this one as well will be uploaded to the same page. Our next upcoming sessions are on Tuesdays in between the month of January and February, as you can see on your screen. Lydia, you let me know whether we can proceed or if there's any other communications you might want to make. But for now, please take note of the sessions that are currently displayed on your screens. This is the program, or rather the schedule for the sessions that we'll be having for cervical cancer this month. And I'll also like to acknowledge all the participants who have said hi to us on the chat box. I can see we are well represented. All the counties are well represented. I can also see we have a couple of people from outside Kenya. We also appreciate your attendance to this session today. I can see Lillian is back. Lillian, can you hear us?
Yes, I can. I just panicked a bit, and I hope everyone will forgive me for that. It's my internet. I'm in the interior part of this country somewhere.
All right, that's no worries. We thank you for even joining us from that remote area, and also we hope that you'll be able to continue with your presentation. If you'll need assistance, you can let us know. We'll be able to assist.
Okay, proceed, Lillian. How of treating the precancerous lesions before it becomes cervical cancer. Take over, Emma.
Thank you, Lydia. And good afternoon, everyone.
To you.
Or morning, depending on from where we are watching from. I want to carry on from where Lillian has left it. Lillian was covering the screening bit, and I'm looking at how we are managing the precancerous lesions at the facility. So we are talking about the screen and treat, where we identify the disease early and manage with provide timely treatment, which helps us to reduce morbidity and mortality and improve outcomes at the community level. So women presenting with precancerous lesions, they should be offered HIV testing, counseling and testing, and immediate referral. Immediate referral for biopsy. And maybe if you bear with me just a minute, I stop sharing. Just a minute. Yes. Sorry for that. So we are saying treatment of precancerous lesion is key in consideration for the success of any cervical cancer prevention. And the screen and treat strategy is about screening and treating the precancerous lesions immediately, which involves treatment with thermal ablation or cryotherapy, the ablative methods. And for patients who are not eligible for the ablative methods, they are managed, they are treated with LEEP or cone knife colonization, which is a surgical procedure performed where indications for treatment of surgical dysplasia cannot be done adequately after evaluation through colposcopy. Like I had said earlier, all the women who are presenting for the precancerous lesions need to be done HIV counseling and testing, and with immediate referral for the patients who identify with precancerous lesions. So we are saying the benefits of screen and treat, it helps to reduce to loss to follow-up, because you identify a woman, you cancel her on treatment, and you do treatment. So you will have met the screening and the treatment objective for that woman. Again, it's cost effective. This woman doesn't need to come to the facility several other times before she gets treatment. And then when we treat precancerous lesions, we are also sure that this woman will not develop cancer, which is expensive to treat. And it also improves treatment uptake and enhances patient satisfaction. We have two ablative procedures, cryotherapy and thermal ablation, which we'll talk about shortly. So cryotherapy, this is where we use, it involves freezing of the abnormal cells and the surrounding transformation zone on the cervix. It requires pressurized gas, refrigerant gases, either nitrous oxide or carbon dioxide to destroy the abnormal tissues. And it uses probe, a tip that is highly conductive metal that delivers compressed gas on the surface of the ectocervix, because we treat on the ectocervix. It is about 90 to 95% effective in treating the high-grade lesions. Sorry. So this is how a cryotherapy looks like, where we have a gas tank, and we have the cryotherapy machine, and the other equipments that are required for screening, just the regular consumables that we take for screening. So what is the eligibility for ablative methods of treatment and cryotherapy? You must be able to visualize the entire cervix. The lesions should not extend to the cervical canal or to the vagina, and the lesion occupies less than 75% of the cervix. The client must also not have any evidence of suspicious for cervical cancer, because if we cannot treat with thermal ablation when we are suspecting cancer, we need to manage it otherwise. And there should be no evidence or suspicion of glandular abnormality. The woman must not be pregnant, and no evidence of STI or pelvic inflammatory disease, any cervicitis, and any other infection. If there, we treat. And at the time of treatment, the woman must not be on menses. And we'll be seeing why that should happen. So the procedure, we apply the tip, like we can see here. It's a 11 minutes procedure. You freeze, for 3 minutes, you thaw for 5 minutes, and then you freeze for 3 minutes, and again, you thaw as you remove. And this is how it appears. The tip appears on the cervix during treatment as it's forming the ice ball. So post-treatment, this is how it appears. You can see the ice ball forming. Immediately after, this is how the cervix is, just to draw that confidence to the service providers of how the cervix appears after cryotherapy. And you can see the cervix here post-treatment. And this should be able to help us, get that confidence that this is an effective treatment and safe treatment for post-cancer. The next method is dermal abrasion. I said we have two, cryotherapy and dermal abrasion. What is dermal abrasion? Dermal abrasion uses heat for highly conductive heated probes to destroy the abnormal cervical tissue, which, if left untreated, it can develop to invasive cancer. The probe heats up to about 120 degrees centigrade. But as we talk about this heat, the cervix does not feel, as you treat the woman, does not feel that heat, so that it doesn't become a hindrance for the service provider to treat the client. Once heated, the probe can destroy tissue up to 4 millimeters deep in 30 seconds. So in that seconds, you're able to do the treatment for dermal abrasion. So it's ideally done in 20 to 40 seconds. And where necessary, you can do multiple overlap applications during that visit. In cryotherapy, you cannot treat, if you apply cryotherapy probe, you can only do it once. But the beauty of dermal abrasion is that you can treat two lesions on the same sitting. The woman in lithotomy, you have seen a lesion on one part of the cervix and another part of the cervix. You can treat the two lesions in two times. It's over 95% effective in treating high-grade precancerous lesion. And this is why we are saying cervical cancer is preventable if women come out for screening early. My laptop is hanging. Wow. Yes, we have two types of dermabrasion machines, the Liga and the WISAP machines. One we heat immediately on the client, and this we preheat before we go to the client. Just covering a little bit of a detail, this is how it appears on the case as presented. Just one caution, because for this, we're not going to the depth of the trainings. This is a probe, a Liga probe. One of the things that I would wish to talk about as we emplace the treatment at health facilities. Immediately you remove this probe from the client. It is important that you don't put it in a cold solution immediately, for it's going to crack. And to replace this, it takes about $90. These are some of the feedbacks we're getting from the facility. There are probes that are cracked, and that's why it's important to talk about that. When we talk about Liga, about WISAP as a machine, it has a power bank. It uses a power bank, and that's why we are able to treat even out when we go for outreaches. We can carry these machines for treatment. These Liga, as we had over in the facilities we take care, we need to take care of this power bank, because if we lose it, then we will not have the power source to treat our clients. And it's one that can be used for multiple use. So when we do the abrasion, this is how it appears. You can see the positive lesion. You can see the positive lesion here. When we treat with dermal abrasion, that's how it appears. And post-treatment, you can see a beautiful cervix, which is healing, and it heals very well. That is one beauty that God created us as women, that the cervix becomes beautiful, it heals very well, and the woman can easily carry pregnancy post-treatment. So post-treatment instructions, when we do this, patients should avoid sexual intercourse or indulging in the vagina. And if the abstinence is not possible, the client should use condoms. And we are doing this to avoid infection. And once treated with cryotherapy or thermal ablation, the client is followed up after 1 year. When you look at, and when you're focusing on the side effects of thermal ablation on cryotherapy, we are saying there are those expected effects. And one, it's short-lasting mild lower abdominal clamping, watery vaginal discharge that lasts 4 to 6 weeks, dependent on each woman. And it's important to discuss about this because a woman will need to wear a liner on pads during the post-treatment period. And if not cancelled well, these are some of the reasons why women come back to the facility when they are anxious and they are worried. So spotting, which is right spotting, that may happen in the 1 to 2 weeks following treatment with slight abdominal pains. So what are the signs that a client needs to identify and come back to the facility? One, if there is presentation of fever that persists for more than 2 days, because that's a sign of infection. Severe lower abdominal pain, and it has fever, it is heavier than it's heavier than what she experiences through her menses, that her worst day on menses. That's a sign of infection. Bleeding for over 2 days that is heavier than the heaviest day of her menses. And if she's experiencing any blood clots or vaginal discharge that has a foul smell. So any patient who identifies these danger signs needs to come back to the facility immediately for further management. When we compare now the two, having done that, we compare the two, cryotherapy and thermal ablation. We're looking at them not really comparing. They're both recommended by the World Health Organization. We know cryotherapy requires oxygen, it's longer minutes, 11 minutes procedure. But the beauty of it does not require electricity, but it has bulk logistics. So it is one very useful, especially where we have challenges of electricity. As we know, our nation, we are all not at one grid. So cryotherapy is handy in those areas. Then thermal ablation, again recommended by WHO, it requires electricity or a battery which has been pre-charged. It is 1 long minute procedure. So making it easier for patients to be treated wherever they are, because then the procedure is only 1 minute long and we treat the precancerous lesion, preventing cervical cancer. It is right and portable and can be carried anywhere. It can actually move to fight the client from where they are, and we treat to prevent cervical cancer. So in terms of follow-up, if lesions do not resolve after thermal ablation treatment, then we consider doing lip or biopsy. That is large excision. So certain lesions persist, 5 to 10%, especially in HIV after treatment with the thermal ablative methods, and where we need to consider to refer to hospitals for advanced procedures or diagnosis. So what are we talking about? LEEP. This is large loop excision of the transformation zone, which was previously called LEEP or electroexcision procedure. So LEEP is an excisional method. You realize with the thermal ablative, you destroy the cells there. But with REETs, you are able to cut off the whole transformation zone and take it for biopsy. So the procedure is both therapeutic and diagnostic. It is non-ablative. So the ablative methods are two. cryotherapy, and dermo. The leads, you actually remove you remove the diseased part, the part that has abnormal tissue, and you take that for treatment. And to combine reads, you also do colposcopy, which is a microscopic examination of the cervix. And with that, you will have achieved the treatment for the precancerous lesions at the facility. And for leads, we are doing for those clients who have a lesion larger than 75%. Remember, for the ablative methods, we said it is the methods, the lesions that are lower than 75%, or those that do not touch the columnar epithelium. So those that get into the endocervix, we commit them to LIPS, and those that are larger than 75%. So this is the algorithm for post-treatment follow-up for general population of women. If treated with dermoablation or excision without histopathology results, or treated based on histopathology diagnosis of CIN2, the precancerous lesion, we follow them 12 months. We can do a HPV test, or we can do the tests that are available. The recommended is a gold standard, the HPV test. If we don't get that, the resources do not allow, then we can do visual inspection with acetic acid or cytology, as discussed by Lilian a little earlier. Negative, we follow up with testing again after 12 months. If negative, again, we return to regular screening as per the national guidelines, as discussed by Lilian earlier. That means if you are doing VIA, then we can do it after 3 years. If you are doing HPV, it's negative, then we can do it again after 5 years. If the client is positive, we are now not going to treat with the ablative methods. We are going to treat with the non-ablative method. And it is preferred that we do reads for that client or cone biopsy, so that we can get a sample to take for biopsy. After that treatment, again, we are going to to do post-treatment follow-up in 12 months. If suspected cancer, then we need to evaluate, do biopsy, and refer appropriately, depending on the level of facility that we are in. And that way, with those steps, then we are able to achieve treatment of precancerous lesions, preventing cervical cancer. I invite questions.
Thank you, Emma, for the good presentation. I'm happy there are some questions that were being asked. And at the beginning, some people are not understanding what RIP is, but I'm happy as you continue to present, at least the name, the RIP abbreviation was written in full. So I can say that it's good because people are anxious to learn more and more. And before then, I think because I'll give our panelists time so that they'll respond to the questions and answers, we are now going to hear one of our warriors because she's going to give us her testimony, her experiences, her advice, especially to us, all of us. And when I say to us, all of us, it's because everyone is affected. It may be a mother, it may be a sister, it may be a wife. We are all together and we are here to learn that we may join hearts together and try to eliminate cervical cancer in Kenya by the year 2030. So I want to ask her, Emily, so that she can make her, she can give us her words. She's very, very passionate. When you see that she's one of the key person to speak in this webinar, it shows that she's very, very passionate and she would wish to help other women. So Emily, kindly take over and you make your way as you advise us, all of us. Thank you. Emily Wekesa.
Okay, thank you so much, Lydia. You can hear me?
Yes.
Thank you so much. Good afternoon, everyone. Once again, my name is Emily Wekesa. I am deeply honored to be here today with all of you as a cervical cancer champion and passionate advocate. And I'm going to take you through, I'm going to share my journey on my experiences. I know it's a personal story, but I believe it holds a message of hope and change for our community and all of us. Uh, Kindly allow me to take you a little bit back. When I was growing up, I really struggled from different diseases, malaria, asthma, head, joint pains, and even mild sickle cell attacks. As you can see, all this displayed my weak immune system. And these challenges followed me into adulthood at the age of 14 years. Unfortunately, I faced a trauma when I was raped by a family member. I carried the pain in silence for the longest time ever. Because of this, I really hated our home because this happened in my home. So, and I was seeing this person day by day. So I really hated home. And this made me to go out. And I said, at the age of 20, I became a mother. But at this time, my menstrual periods were extremely painful. I welcomed my second child after 4 years apart. At this moment, my periods were irregular. I could see my periods 2 to 3 times a month with heavy clots. And these are things that I ignored, or maybe I thought this was normal. And in African culture, as girls, you are told that anything between your legs, it is your secret. So it was very hard for me to open up. I had no knowledge of cervical cancer or screening. In fact, I believed that cancer was a disease for wealthy people and white people. I mean, wazungus in Kiswahili. So I was really naive. In the year 2020, the symptoms worsened with prolonged bleeding and severe back pain. And this forced me to see a doctor. After several tests, and the test included pap smear, and pap smear was for me, it was the first time hearing the word pap smear. So the doctor took a sample for pap smear, and they did a sample. I went through MRI, then biopsy, CT scan, then PET scan. And after a few weeks, I received my diagnosis that I was at stage 2D of cervical cancer. My world collapsed. To me, cancer was meant death. I was in denial the first few months. I started preparing my funeral. I'm a Catholic, so I was preparing the mass, everything, even writing, requesting letters to the priests whom I wanted them to come and conduct my requiem mass. But through the support of my churchmates, few friends, family, husband, and children, I made a choice. I chose to fight because I really wanted to live to some point. By then, I was transferred to Cancer Center where I met with my oncology doctors. The doctors took me through my treatment plan. And my treatment plan included chemotherapy, radiotherapy, brachytherapy, and lastly, surgery. The journey through cancer treatment was never easy. It was full of pain and uncertainty. I've been in ICU for more than 3 times. And at some point, I woke up one of the days between my treatment. I could not see. I lost my vision for some few days. I also lost my uterus, my investments, my beautiful house in Mombasa, and my well-paid job in UAE. Yet, I still thank God for the gift of life today. My brothers and sisters, cervical cancer is real, and it is preventable and treatable. My story is not just about me, it is about us. When one woman survives, her children keep their mother. Her family keeps its pillar, and community keeps a leader. Women are leaders. To all, but many women suffered in silence. Stigma and fear stops them from screening. Many believe that cancer equals to death. Some say cancer is witchcraft. Some say what you don't know will never kill you. These are all wrong. We must break these myths. Community must embrace screening as a routine. Men must support their wives, sisters, mothers, and daughters. Parents must protect their girls with HPV vaccine. HPV vaccine. In 2021, my treatment came to an end, but I wanted to learn more about cervical cancer because by then I knew nothing about cervical cancer. Through Kilele Health Organization, I was privileged to be part of United Cervical Cancer Elimination Team of Advocates Conference in Botswana. I learned about HPV, early detection, HPV, and cervical cancer, and WHO targets of 90. As we all know, knowledge is power, but applied knowledge is wisdom. Armed with this knowledge, I returned home with a mission of advocating for screening, early detection, and HPV vaccine. Sorry. Since then, I have reached out to numerous students, men and women in various schools, groups, churches, and community gatherings. I always explain the importance of self-awareness, early detection, and timely treatment. I assure women from different communities that they understand the significance of screening and the HPV vaccine for our girls. To my fellow women, please make cervical cancer screening part of your routine health care. Do not wait for symptoms. This is my 6th year of survivorship. I stand as a living proof that cancer, it is not a death sentence. Cancer, it is treatable. Cancer is preventable if we work together with the medics community, anybody involved in this fight, so that we can achieve the 90-70-90 targets to ensure that we eliminate cervical cancer in our communities. If only I knew what I know about cervical cancer today, I will not have lost my uterus, along with my investments. My people, screening and early detection saves lives. And together we can eliminate cervical cancer. Thank you so much for this opportunity.
Thank you, Emily. I am happy you have spoken without fear because you want to help us today to be a remarkable day, 20th January 2026. And I believe that whoever has heard your journey will never forget the words that you have spoken this afternoon. And so I think this is a call to all of us that we should join hands and work without fear, be champions on this area of elimination of cervical cancer, because together we can make a change. I want to say thank you to all our listeners. I can see that we are a mixture because we have academians with us, we have our professionals, other professionals with us, and this is a great day that we want to hear more, and we are eager even to do more and even also to apply the knowledge. I have a list of questions. We may not be able to address all of them, but at least I'll pick a few. And I want to say that I'll pick a few because of the time, and also to give my panelists enough time to respond to those questions. I think I'll start with the questions, but I want to say that Emma, in case Lydian is still not with us because of the network issues, Emma, you can respond to both questions because I know all of us, we are here in this cervical cancer space trying to work together so that we can be able to create awareness, also to train our healthcare workers in this country, 47 counties. We have trained all healthcare workers in almost all the facilities, starting from level 2 to the highest level 6. So in case of any question, I think, Emma, you'll be in a position to address all of them. And I'll start with the first one. And the first one is about asking, what is your view on annual pap smears as part of individual wellness screening?
Come up again, Lydia, shortly, sorry.
Okay, what is your view on annual pap smears as part of individual wellness screening?
Thank you for that question. When we are talking about screening, if you have been going for regular screening, we are saying if it's negative, we can rescreen after 3 years, but also looking at the risk factors that are there for cervical cancer.
Okay, thank you.
But
Yeah,
remember, the gold standard, like Lilian covered, is the HPV testing. If you do the HPV testing and you are negative, that is for age 30 years and above, then you can rescreen again after 5 years. Thank you.
okay, good. The other question will go to Lilian. I can see she's she's with us as a panelist. The question states, how do you handle someone who has done HPV where the test for high-risk HPV is negative, but the report says she has other non-specific HPV virus positive?
Thank you, Lydia. I would say that when other types of HPV are positive, I believe they can be handled by the clinician who sent for the test, so that it's each test has a specific way to handle it. If it is HPV, you handle it as, if it's HPV 16 and 18, you handle it as it is, by doing either colposcopy, or you triage with the VIA to see if there's a lesion, and then to see if it could be treated. But if it is not for HP, for it is HPV positive, and it is not the type that is causing cervical cancer, then it will be handled according to the specific virus that has been seen. Thank you.
Okay, thank you, Lilian. I am happy you have talked about the HPV type 16 and type 18. There's a question that follows that someone is saying that she has a friend who tested HPV 16 positive, but HPV 18 was negative. And so she's asking for an advice, and I think it is a question that follows your explanation, Lydian.
Yeah, I can say that they don't have to be positive, both of them, that they must be positive 16 and 18. It could be either positive 16, it could be either positive 18, or it could have both. So still the care will be given the same. The triage will be done, and check if there's a lesion, or if there's no lesion, then appropriately will be guided by maybe rescreening after, again, 12 months.
Then after 12 months. That means after 1 year. I hope it's clear to everyone. Okay, there is a question that follows also, and it is asking about the levels, because the question states, what centers avail HPV DNA tests? Like, are they accessible at level 3 and 4 in majority of the centers? Lilian?
Yes, when the HPV DNA tests are available, normally they are distributed to all facilities in the county. They're distributed to the county, and the county distributed to the facilities. So normally we should contact the county laboratory, the county lab coordinator. They are the ones who are receiving these tests, and all counties are normally supplied with the HPV DNA test kits. So they distribute it downwards to other facilities.
Okay, thank you. Now, I think I want to join two questions together. One is that so that Lydian, you can address both instead of keeping on calling you. But regarding screening intervals for HIV positive women who are HPV negative, does viral load and CD4 count affect the interval?
Lydia, what was the question?
regarding screening intervals for HIV positive women who are HPV negative, does viral load and CD4 count affect the interval?
No, it doesn't affect the interval. The interval remains 3 years when you use HPV test, and
Okay.
1 year if you're using VIA or cytology. So it does not affect the interval.
Okay, thank you. So I want to say that I'll try to rescue Lillian at the moment so that she can have a breath, and then I'll come to Emma. What is the best treatment a 40-year-old para-5 HIV negative with biopsy of CIN1? What's the best treatment? I repeat again, Emma.
Yes.
What is the best treatment of a 40-year-old para-5 HIV negative with biopsy of CIN1?
Thank you for that question, Lydia. If all treatment methods are good, the thermoablative method, you give it at the woman will not need to come back again. But the lip method, it means you'll get a biopsy to see. So I would say either method would be good for the client, having cancelled the client. But CIN1, it's still early, so you can give the ablative methods.
Okay. Thank you, Emma. I want to take you back, Emma, because you are the one who was dealing with the issues of treatment. The question states, can you do VIA after HPV results are positive, then do TA, that is dermoabrasion, if the lesion is below 75%?
Yes, thank you for that question. Remember, for us to have the positive lesions, the patient will be HPV positive. So when you do visual inspection with acetic acid, it only confirms the precancerous lesion where it is. Yes, if it is below 75%, we can treat with dermoabrasion.
Okay, thank you. Lillian, I want to come back to you as Emma has a breath. Now, there's a question here, and he's saying that, please, it is starting with the statement, please let me know what is the right age for HPV testing. Some children between 9 to 14 years of age are already exposed to sex, maybe through abuse. Is it wise to test for HPV before getting the vaccine?
Okay, thank you for the question. For testing, HPV testing, that one we are talking of screening, and I hear there is a mention of children. So if it is HPV testing, it is 30 years. That is where we begin our testing. For women, HIV negative. For women, HIV positive, it is 25 years. For children, we give HPV vaccine, where we give it as a single dose for 10 years. So that they get the primary prevention early enough. So for testing, it is not recommended that we test the children for HPV before giving the vaccine. When you get the 10-year-old girl, just give the vaccine. It does not matter whatever. Do not take the history that have you ever had sexual intercourse, because we imagine that children at that age still have not been exposed, but you just give them according to the guideline that it is 10 years old to get the HPV vaccine, not HPV DNA test screening. Thank you.
Okay, thank you, Lilian. Now, I just want to come to Emma. Emma, there is a question that has been asked by one of our seniors, and I think he's in Machakos. I know him, and this is an evidence that the knowledge that we are getting is that even when we become senior, we should keep on giving the knowledge to the others who are younger than us, that we may continue mentoring, because our role is to keep on giving information. The senior asked this question. I know him anyway. That is why I'm saying he's a senior, because I know him. And he asked a question. In thermal abrasion, bearing in mind it is 100 to 120 degrees hot, is the woman anesthetized?
Okay. Thank you for that question. I think I had answered that question. I had answered, as I've answered most of the questions on typed in, but the answer is yes, we use the thermal apparator at 100 to 120 degrees. The cervix anatomically is poorly nervated, and therefore the woman does not feel pain. And this is one of the conflicts that comes for the service provider when they are offering treatment, because they think the woman will be feeling pain. So if you apply it correctly, the woman will not be feeling pain. And as we said, it treats for about 4 millimeters. At that length, the client will not feel any pain. So we don't need to give anesthesia. We don't need to give an.
Okay, thank you. Noted, Emma. Thank you.
Thank you.
Yes, thank you, Emma. But I want also to give you another question, because you are very passionate in this area, especially dealing with the women who are above 50 years. The question is, how can you monitor breathing for a postmenopausal client after surgery?
If a woman
I repeat.
thank you. No, it's okay. I've had that question, Lydia. Thank you. And thank you for the question, for whoever asked the question. Post-surgery monitoring for a patient who has done, I want to imagine this is I don't know, it would have been more specific, but if you're talking about uterine surgery, there will be PV breathing, and you check in terms of pads, any breathing per vaginal, and if they have any pads, the amount of pads that they have sold. It should be able to guide you on the amount of breathing, whether it is what is expected or it's above what is expected when the patient has excess breathing. And then you also go for the clinical parameters for the client. Thank you.
Okay, thank you so much. I have two questions that are remaining, one for Lillian and another one for Emma. As my panelists have expressed, already they have tried to answer to the questions and to give the answers to the questions that you have answered on the chat. But I'll ask them each one question, and that is Lillian will start with the first one. And I'm happy because you people, I can see you are agreeing. It is not only one gender can be able to help us in this space of trying to eliminate cancer in our country. Now, the question is this, Lillian. What is the role of men in cervical cancer prevention? Can they do HPV DNA as well? Should this test be done before marriage for both? It's a very good question and very interesting and making us to wake up this afternoon. So I want to repeat. What is the role of men in cervical cancer prevention? Can they do HPV DNA as well? Should this test be done before marriage for both?
Yeah, thank you, Lydia, for that question and for the person who has asked it. For men, we cannot do HPV DNA test, but they can support the women by encouraging them to go for screening. If it's a couple, you accompany the couple, you accompany your woman to go for screening. If you have a daughter, also you can also be part of taking your daughter to be vaccinated. And also just checking another way of support is by also checking just the behavior, the sexual behaviors, whereby you have one partner and not many partners. So basically, the support that they can give is working together with the daughter and with the wife or a sister or a mother, or they can do the advocate, or they can advocate on it. Thank you.
Okay, thank you, Lillian, and the one who asked that question. And now my last question is going to be responded by Emma. Emma, this is the question, and this is I'm saying that this is a very wonderful webinar this afternoon. I've not been thinking that people have been seeing beyond the box. The question says, we have a lot of GBV, gender-based violence cases in our society. To be specifically sexual abuse, our girls and young mothers suffer this. I don't know, is HPV test among the first line-based tests for management, or it's an option?
Lydia, I didn't hear you some places. You're sounding very, very far away from the mic. Sorry for that.
Sorry, let me repeat, my dear. We have a lot of GBV cases in our society. To be specifically, sexual abuse. Our girls and young mothers suffer this. I don't know, is HPV test among the first line-based tests for management, or it's an option?
Thank you. Thank you for that question, and thank you for starting asking that question. When we do, yes, we have GBV cases, but we also look at the pathogenesis of HPV. When one gets infected with HPV, it takes about 10 to 15 years to actually give us, to actually produce, show us signs of cervical cancer. And therefore, it is not for first aid treatment when we're doing the HPV, the effects of that. And we also know with infection of HPV, in the initial phases, it wears off. If the immunity is good, it wears off. So it takes some time to get the effects of HPV. And that's why we do the HPV testing from 30 years, just to give that transient phase of where it wears off. We know with infection, with the non-reinfection, it can sometimes wear off. So for now, in our guidelines, it's not part of first line options testing. And I would also base it on the HPV pathogenesis part of it, that it may not really be beneficial to do that test immediately. Because even if you capture HPV, we do not have any treatment for HPV, and that's why we do not screen men, but we have treatment for the effects of HPV. That's why when a woman tests HPV positive, we say she's high risk. If she does not present with a precancerous lesion, we continue to screen until she presents as HPV negative. Thank you.
Okay, thank you, my panelists. Now I want to have this time to give you at least each a minute to give a parting word. That is a parting shot. And I'll start with Emily. It's 8 minutes to our time, 7 minutes indeed.
Thank you so much, Lydia. Mine is going to be very short. What I can say is many women fear the word cancer, but when we talk openly, we continue talking openly, we replace fear with hope. Thank you.
Okay, thank you. Lillian?
Thank you, Lydia. And thank you everyone for joining this call. This is a learning platform where we gain a lot of knowledge, things that we didn't come here knowing. And we also appreciate your questions. And just say that this is Cervical Cancer Awareness Month, and I would encourage us to really do a lot of advocacy where we are so that many women can go for screening. So let us screen many women, as many as possible, including ourselves, so that we reach the target of cervical cancer elimination by 2030. Otherwise, wishing you well this month, and please wear teal always in this month. If you are able to put on your ribbon, the teal ribbon, so that it can communicate cervical cancer, please do so. Otherwise, thank you very much.
Okay, thank you, Lillian. Emma?
Thank you, Lydia, and thank you everyone who has joined this call this afternoon. I pray that you are inspired to join the LACE, and you've joined the LACE because you are here to participate. I wish to encourage all of us that we continue with the advocacy and taking a step further to go for screening and to encourage those that are around us to go out for screening. We cannot be able to treat if women do not come out for screening. And therefore, I pray that we will get all those around us. The 1,300 of us, if we each reached 10 women, that is 13,000 women who will be screened, and that will be great. So I pray that we do that. For those that are asking questions about trainings, especially from the private sector, please liaise with the National Cancer Control Program office, and we should be able to reach out to you. Thank you.
Okay, thank you. Thank you, my panelists. I also take this opportunity to say that the National Cancer Screening and Early Diagnosis guidelines is in the MOH website. You can download, you can read more, because we have just, whatever we have covered today is just a nutshell. And I, Emma, and Lillian, we are also contributors of this guideline. So in case of any question, as my panelist has said, feel free to reach the National Cancer Control Program, whereby we shall have a chat together and we discuss more and be able to try to address the needs that you have. Otherwise, we say thank you so much. I want to say thank you to all the listeners this afternoon. Kindly, let's keep on deciding to know more and more, because the more we know, the more we are able to save the situation in this country. I can see somebody from Kakamega KMTC. Thank you also for joining us. That's why I'm happy, because all the institutions, I can say, at least in this webinar, they are well represented. Others, I say thank you, and I want to thank the Kenyatta National Hospital platform for always working with us and supporting us. Back to you, Nelson. As I say, thank you again and again, even on behalf of our head National Cancer Control Program, Dr. Joan Paula Bo. Thank you. Nelson? He seems to be far.
Good afternoon.
Good.
And Nelson has stepped out for a moment. He's just coming.
Okay.
Just one moment.
Okay. Okay, meanwhile, Beatrice Ocheng can be saying something. She has done a lot to organize with Nelson. Beatrice from NCCP, Beatrice Ocheng.
Thank you so much, Lydia, for such a wonderful webinar that you have delivered. And I also want to thank the panelists for today. Lillian Genga from National Cancer Control Program, Madam Emma Karaoke from Women for Cancer, and our champion, Madam Emily Wekesa. Thank you so much for that wonderful story that you gave to us. Very, very much inspiring. And also thank you so much to the KNHUN team. You have been very helpful for the program in having these webinars ongoing every Tuesdays. And we continue to thank you. We had
Yes, team, this is Nelson back.
This is the schedule that we have. So we'll continue giving you the webinars each and every week. Thank you so much. And over to you, Nelson.
Yes, apologies, I had to step away from my desk for a bit. But as communicated, our sessions are still on, and you'll receive notifications on them on your email addresses. As mentioned, this session will be uploaded to our YouTube page. So kindly visit our YouTube page for this and past sessions so that you can view the recordings. Thank you once again for joining us. Do have a wonderful afternoon.
Thank you.
Thank you.